Hello guys, today we talk about dislocation of the upper limb and first about what we will talk there. It is dislocations of shoulder or shoulder dislocations. I want to joke that head and shoulders and shoulder dislocation. Okay, understand, bad joke, and we start talking. Traumatic dislocations of the shoulder reach 60% of all dislocation as a result of anatomical and physiological features of the joint. First of all, is the spherical head of the humerus and the flat articular cavity of the scapula. The discrepancy of their sizes, a large joint cavity, weak ligamentous, capsular apparatus, especially in the anterior part, posterior muscle work, and a number of other factors contributing to the occurrence of dislocations. In relation to the shoulder blade, there are anterior, lower, and posterior dislocations of the shoulder. Anterior dislocation occur more than 75%, axillary ones make up 24%, and the rest 1%. And I think that it is easy to understand that we have front, lower, and posterior dislocations. Mechanism of injury, how you remembering of all dislocation, it is indirect, yeah? And the mechanism, it is a failing on the withdrawn arm in the position of anterior or posterior deviation. Excessive rotation of the shoulder knee in the same position. And there you can see the patient in time of the fall. And there too. Complaints of pain and cessation of functions of the shoulder joint which occurred after the injury. The patient holds the injured arm with his healthy hand, trying to fix it in the position of withdrawal, and some deviation from the front. The shoulder joint is deformed, flattened in the anterior-posterior direction. The acromion will stand under the skin. There is a trap under it. All this gives the joint a characteristic appearance. And in the picture you see it. During palpation, a violation of the external landmarks of the proximal shoulder is determined. The head is probed in an unusual place for it, more often inside or down from the articular cavity of the scapula. Active movements are impossible, and an attempt to perform passive ones reveals a positive symptom of spring resistance. The rotational movements of the shoulder are transmitted to the atypically positioned head. Feeling and determining the motor function of the shoulder joint cause pain. Movements in the distal joints of the arm are preserved in full. Movements as well as skin sensitivity the surgeon must necessarily determine. You remember, yeah? Since dislocations can be accompanied by nerve damage, the axillary nerve most often. Damage to the main vessels is also possible, so you should check the pulsation on the arteries of the limb and compare it with the healthy side. Radiography. The leading Auxiliary method of examination for shoulder dislocation is radiography. Without it, it is possible to make a final diagnosis, and an attempt to eliminate dislocation should be attributed to medical errors. Without an X-ray, it is possible not to recognize fractures of the proximal end of the humerus or scapula, and during manipulation harm to patient. The dislocated segment must be corrected immediately after diagnosis. Anesthesia can be both general and local. Preference should be given to anesthesia. If we talk about local anesthesia, it is performed by injection a 1% procaine solution in an amount of 20–40 ml into the joint cavity, after a preliminary subcutaneous injection of a morphine or dimesteridine solution or another anesthetic what you have. The reduction of the shoulder joint without anesthesia should be considered a mistake. Before removing the dislocation, it is necessary to get in contact with the patient, calm him down, determine the behavior at the stage of correction, achieve maximum muscle relaxation like this cat on your slide. Examination of dislocation. There are more than 50 ways to eliminate shoulder dislocation. The most famous is the Kocher method. Science 1870. The patient is sitting on a chair. A towel in the form of an H-shaped loop covers the damaged shoulder. You see it in picture. Yeah, this one. This one. Shaped loop covers the damaged shoulder joint, creating a counter pull. The doctor places his arm, the same as the dislocated one, on top of the elbow band and covers it. The second hand holds the wrist joint. Yeah. You see that he try push it down, pull it down, and in right side, then try some deviation, some rotation. He need to take it on the place. And look to these guys. He don't like this situation, I think. The second hand holds the wrist joint, bending the limb in the elbow joint at the right angle. Further, the doctor's actions consist of 4 stages. Stretch the limb along the axis and bring the shoulder to the trunk. Continuing the movements of the first stage, rotate the shoulder outward by deflection the forearm in the same direction. Without changing the achieved position, and traction moves the elbow joint anteriorly and inwards, bringing it closer to the midline of the trunk. Perform internal rotation of the shoulder by the forearm, moving his hand to the healthy forearm. The Kocher method is one of the most traumatic. It is usually used in young people with anterior shoulder dislocations. In elderly people, this method is not used because of the threat of fracture of the shoulder bones and other complications. There is a group of methods based on the reduction of of the reduction of dislocation by stretching. Often stretching is combined with rotational or rocking movements. The most ancient in this group is considered to be the Hippocratic method, 4th century before our days. The patient lies on a couch on his back. The doctor places the heel of his bare foot, the same as the dislocated arm of the patient, in the axillary area of the patient. Seizing the victim's hand produces traction along the long axis of the arm, with simultaneous gradual reduction and pressure with the heel on the shoulder, head, outward and upward. When the head is pushed, its reduction occurs. There are methods of the Chamberlain and Kudravtsev. In the first case, traction for the limb is performed using a suspended arm cargo, and in the second, with the help for a cord thrown over the block. Yes, there is a Kudravtsev, there is a Chamberlain. And method Genelidze is considered the most physiological and atraumatic. The method is based on muscle relaxation by stretching the affected limb by gravity. The patient is placed on the dressing table on his side, so that the dislocated arm hangs over the edge. Yes, one table, one chair. And a high table or bedside table is placed under the head. The trunk is fixed with rollers, especially in the area of the shoulder blades, and the patient is left in this position for 20–30 minutes. Muscle relaxation occurs. The surgeon sizing the bent forearm of the patient produces traction down the course of the arm, followed by rotation outward and inward. The reduction of the shoulder can be determined by the characteristic click and restoration of movements in the joint. After close or open shoulder reduction, the limb should be immobilized like always, with a plaster splint along the toner from the healthy upper arm to the heads of the metacarpal bones of the damaged limb. The period of immobilization, in order to avoid the development of habitual dislocation of the shoulder, should be at least 4 weeks in young people, about 2–3 weeks in older people. In the elderly and silently people, kerchief bandages are used for a period of 10–14 weeks. Days. Physical therapy. There we use analgesics, UHF on the shoulder joint, static exercise therapy, and active movements in the joints of the hand area prescribed. After the elimination of immobilization, physical therapy of the shoulder joint is prescribed. Exercise should be of passive and active types, aimed at restoring circular movements and shoulder retraction. During therapeutic gymnastics, it should be monitored so that the movements of the shoulder and shoulder blades are separated, and in the presence of shoulder syndrome, the shoulder moves with the shoulder blade. The methodologist needs to fix the shoulder blade with his hands. Rhythmic galvanization of the shoulder and upper ab muscles procaine electrophoresis, also carried laser beam, magnetotherapy, classes in a swimming pool, lessons in a swimming pool, exercise in a swimming pool are also used. Recovery of walking capacity occurs after 4-6 weeks. Habitual dislocation of the shoulder. Sometimes repeated dislocation occurs without much violence. It is enough to move and rotate the shoulder outwards. A swing of the arm to hit the ball, an attempt to throw a stone, lying hands behind the head when putting on clothes, combing, etc. Periodically, dislocations of the shoulder can occur in a dream. Such dislocations are called habitual. The most common habitual dislocation is a complication of traumatic anterior dislocation due to errors of medical personnel, neglect of anesthesia or its inferiority, rough methods of correction, insufficient immobilization or its absence, early physical exertion. As a result, the damaged tissue, capsule, ligament, and muscles surrounding the joint heal by secondary tension with the formation of persistent scars. Muscle imbalance appears. There is instability of the shoulder joint with the outcome in the usual dislocations. In the anamnesis of such patients, traumatic dislocation of the shoulder, after which dislocations began to recur without significant load. A retrospectivity study of the treatment of primary trauma, as a rule, reveals a number of gross errors. Repetitions of dislocations are also observed as their frequency increases. The load necessary for their occurrence is reduced, and the method of their elimination is simplified. As a result, the patient refuses medical care and eliminates dislocations. Independently or with the help of others, after reduction, as a rule, pain in the shoulder joint is noted, which passes within a few hours, sometimes 1-2 days. External examination reveals atrophy of the muscles of the deltoid and scapular regions. The configuration of the shoulder joint is not changed, but its functions are sharply disrupted. It is noted that the active external rotation of the shoulder is limited when it is withdrawn to 90 degrees, and the forearm is bent due to fear of dislocation. We call it Weinstein symptom. Passive rotation in the same position for the same reason, it is a Babbage symptoms. Stepanov's positive symptom, it is checked in the same way as Weinstein symptom, but with the difference that the patient is placed on a couch on his back. It show them on back lay, performing shoulder rotation. The patient cannot reach the back of the patient's hand to the surface on which he lies. There he can, there he can't. An attempt to passively bring the arm to the trunk, which active resistance of the patient on the side of the lesion in easily possible, on the healthy side not. On the healthy side not. For example, take these arms, and patient do a pushing down, and you try to push up. And with normal healthy arm, he can do a normal move, and you hard to do the push-up. And when you work with non-healthy, with dislocation arm, it hard for him to push your arm. When lifting the arms up and simultaneously deflecting them posteriorly, the restriction of these movements. Oh, sorry guys, I checked. The next one is about what I want to say. And there just passively bring the arm to the trunk with active resistance of the patient on the side of the lesion is easily possible. Oh no. No, I'm right. The symptom of seizures when lifting the arms up and simultaneously deflecting them posteriorly, the restriction of these movements on the side of the lesion is noted. Treatment. Patients with habitual dislocation of the shoulder should be operated on since conservative methods are ineffective. We successfully applied the methodology proposed by academician of the Russian Academy of Medical Science, Dr. Krasnov. Yeah, and you see moments of operation there. We open the joint, we take out some ligaments and do a small anastomosis between muscle and joints. And today that's all. Thank you very much for your opinion, and in next time we will talk about frequent dislocation, and that will be elbow and first finger. It will be interesting. Thank you very much for your opinion. Bye bye, be healthy, and don't worry, all will be better.